Good afternoon, everyone, and welcome to TxRx, a community of practice echo. Please note that we are recording these sessions for later distribution. Anything listed in the chat does not appear in the recording. My name is Shreya Prasanna, and I will be facilitating today's session. A few quick announcements before we begin. To help us with attendance, please enter your name, affiliation, and email into the chat, which can be accessed by clicking on the speech bubble on the navigation bar at the bottom of your window. If you're one of our BWell Texas providers, please make sure that you identify yourselves during this session. If you're joining via phone, please email your phone number and email to bwelltx@utisca.edu. We'll drop this email address in the chat. Some housekeeping, please stay muted unless you're speaking. If you've joined by computer, your mute button is on the bottom left of your Zoom controls. If you're on the phone, just press *6 to unmute. We encourage everyone to speak at these sessions, especially during the discussion portion. We want to hear from as many of you as possible, so please keep your comments brief to allow time for others to speak up. Or if you prefer, you can use the chat feature to raise comments and questions. Please note that no protected health information is allowed in either the chat or the discussions. If you'd like to view closed captioning for this session, please navigate at the bottom of your Zoom window and select Show Captions option. Towards the end of the session, the BWell Texas team will send out a link to an evaluation survey. All participants filling out the survey will be automatically entered into a raffle for a $30 Walmart gift card. Besides that, you can give us valuable feedback to help shape these sessions. Our didactic today is on alcohol use interventions, harm reduction, and pharmacotherapy, and will be presented by Dr. Brayden Kameg. Following that, we will discuss a case presented by Elisa McElwinney. We will start with introductions, followed by didactics, BWell program announcements, case presentation, and open discussion. Thank you all again for joining today's Echo. In the spirit of all teach and all learn, we look forward to learning alongside all of you and encourage you all to share your experiences, questions, and insight in today's conversation. And with that, we will do some introductions. Dr. King. You're muted, Dr. King.
Oh, being good. Hi, everybody. I'm Ben King. I'm an addiction psychiatrist professor at UT San Antonio, and happy to be here.
Thank you so much for joining us today. Dr. Walker.
Good afternoon. Crystal Walker, doctorally trained PA and the Director of Substance Use Disorders Clinical Services for My Health, My Resources of Tarrant County.
Thank you so much. Dr. Kameg.
Hello. Thanks for having me today. My name is Brayden Kameg. I am a psychiatric mental health nurse practitioner. I'm in Pittsburgh, Pennsylvania, so a ways away from all of you, but I coordinate our psych mental health NP program at the University of Pittsburgh, and then I work clinically in our addiction psychiatry program at the VA Pittsburgh healthcare system.
Thank you so much for joining us today. Elisa McElwinney. I'm sorry, I'm not sure if I pronounced your name correctly.
It's close. It's McElwinney.
Okay.
Yeah. Hi, everyone. My name is Alyssa McElwinney. I'm a psychiatric nurse practitioner at Healthcare for the Homeless Houston. I've been doing psychiatry for about 10 years, addictions for about 3 years, and I'm going to present just the case study today.
Thank you so much for joining us today. Andrea Hebler.
Hello, everyone. My name is Andrea Hebler, and I am one of the program coordinators at CSTEP. Happy to be here.
Thank you. And Jasmine Vidal.
Hello, everyone. My name is Jasmine Vidal. I'm a CSTEP program coordinator. Thank you for joining us today.
Thank you so much. And with that, we will begin with our didactics. Brayden, whenever you're ready, you can take it away. Thank you so much.
Okay, bear with me 1 second. You guys can see my slides.
Yes.
Okay, so as mentioned, we will go over the management of alcohol use disorders. We'll talk a little bit about motivational interviewing, which I am thinking is probably going to be a review for most people, but I think it's helpful just to have that reinforced. And then we'll talk a little bit about harm reduction before moving into the case presentation. Okay. I don't have any conflicts of interest to report. Just going through the learning objectives. So we'll talk a little bit about recognition of alcohol use disorders in clinical settings. We will go over the SBIRT screening, brief intervention, and referral to treatment model. As I mentioned before, we'll review motivational interviewing techniques and harm reduction techniques that can be incorporated into clinical practice when working with individuals with alcohol use disorders. And then lastly, we will talk about pharmacological treatment interventions for alcohol use disorders, including FDA-approved treatment interventions in addition to off-label interventions. Okay. Well, you're all here today, so I'm sure this is not news to anybody, but we know that alcohol use disorders are exceedingly common, both globally and in the United States. We know that they're a pretty significant contributor to morbidity, mortality, and lots of, chronic, not just health, but also psychosocial problems. In my work, I probably see more people with opioid use disorders than I do alcohol use disorders, but it's a mix. I always say we talk a lot about opioid use and reducing opioid overdose and all of those great harm reduction strategies, such as fentanyl test strips, naloxone, but we don't hear as much, not only in the media, but kind of in our healthcare spheres as it relates to harm reduction for alcohol use, despite the fact that we know it's a significant contributor to morbidity and mortality, as I mentioned. We know that psychiatric comorbidities frequently co-occur with alcohol use disorders. So in my role, I manage both the substance use issues in addition to psychiatric comorbidities. The other thing to think about is when we look at alcohol use disorders, we see about 15% of them developing during adolescence. So we know this is something that can impact people really across the lifespan, across different phases of their lives. I find, when we think about alcohol use during adolescence, oftentimes we have people underreporting, or teens go under-recognized and underdiagnosed, sometimes until later into adulthood, where it's a little bit more difficult to treat. We'll talk later today just about treatment and the low numbers of people with alcohol use disorders who ultimately do seek treatment. This is just recent data looking globally at the prevalence of alcohol use disorders. You can see the United States, fairly high rates, as high as 10 to 15%. And remembering that we know those numbers are high, but we also know there are lots of people, you'll see them in your clinical practice settings, that meet criteria for alcohol use disorder, but who are not accurately or efficiently recognized and referred to treatment if that's needed. I won't go over the alcohol use disorder criteria, but just as a refresher, when we think about the diagnostic criteria, people don't need a ton of symptoms to meet criteria, right? So we have lots of people with mild alcohol use disorder who are really having significant impairments in their life that are not, being referred or treated as appropriate. So looking at some more recent data, this is from the SAMHSA National Survey on Drug Use and Health. It's the 2022 survey, but this data was just released probably within the last 2 weeks at this point from the 2022 survey. The National Survey on Drug Use and Health, it's a nationally representative survey. It covers the entire United States, and it goes through questions related to substance use, other physical and mental health comorbidities. But when we look at rates of substance use disorders, this is among people 12 and up, about 17% of people in the United States had a substance use disorder in the past year. That is really astoundingly high. Looking at alcohol use disorder specifically, about 10.5%, 11% of people had an alcohol use disorder in the past year within the United States. So 1 in 10. When you think about, regardless of your practice setting, the volume of people that you're seeing in a day or a week or a month, just thinking about this data, you can kind of extrapolate the likely number of patients you're seeing with alcohol use disorder in your practice setting. These are really high numbers, and it's something that consistently has fallen in this range. We've not really seen a reduction in alcohol use disorders within the past few years. So getting into identification of alcohol use disorders, as I mentioned, I'm going to go over this using the SBIRT screening, brief intervention, and referral to treatment model, which is something that hopefully many of you are familiar with. So when we think about screening for alcohol use disorders, there are quite a few different screening tools. What tends to be recommended now is the alcohol use disorders identification test. It's a 10 item screening tool. There is an abbreviated version called the Audit C that are the first 3 questions, and then if they score positively, you can go on to a full audit. I use the audit pretty routinely. I use the audit for all patients on their initial evaluation, and then typically annually, if they have an alcohol use disorder, obviously I do more than just the screening. I prefer the audit, right? Because it's pretty standardized. It's pretty objective. I feel like it's getting really clear information as far as the frequency of alcohol use and the quantity. There's another screening tool that maybe some of you are familiar with called the CAGE that I just find tends to be a little bit more subjective, and I don't think we get as rich of information as compared to the audit. When we think about the audit, right, incorporating it into our practice, can be done in quite a few different ways. You could read these questions to patients. I find that it's just a little bit more streamlined and efficient to allow the patient to answer these questions themselves. This can be done through pen and paper. We give our patients an iPad and they fill out the questions, and then we can see their responses before we even start the interview. When we think about the results of the audit, they come up to a quantifiable amount. So we have this sort of risk stratification, right? We have low risk, which patients are scoring between 0 and 7. Not really any further action is needed, but I do think it's best practice to at least follow up. They completed this screen, so I think it's helpful to at least acknowledge that you reviewed it. You could potentially go over, safe drinking guidelines if that's appropriate, and we'll talk a little bit about that later. As the number increases, so does your concern, right? So if we have people that are scoring, above an 8, that really warrants feedback, a brief intervention, which we'll talk about shortly, and certainly a little bit more of an exploration or an interview related to their alcohol use patterns. I love the audit as a screen, but I think, an interview speaks for itself as far as the nature and the quality of the information that you're getting. So if you have a positive score on the audit, you certainly want to explore that in a little bit more detail as it relates to precipitants to alcohol use, the duration and things like that. As I mentioned, as the number gets higher, so does our concern. So when we look at risk stratification, if people are scoring above a 15 on the audit, not that this is completely diagnostic, right? It's a screening tool, but that would increase our concern for potential alcohol use disorder, right? Where we may need to do a little bit more thorough of an interview. We may need to consider treatment such as detoxification, which I think last month's presentation reviewed that, or medications, which we'll talk about a little bit later. So you do the screen, moving on to a brief intervention. Motivational interviewing really is the crux of a brief intervention. When we think about motivational interviewing, we're really trying to use this patient-centered approach, recognizing that patients are the experts in their own lives. They're the experts of themselves. We as healthcare providers have expertise in managing alcohol use disorder, but we may not have the knowledge or understanding of the patient's lifestyle to just be able to dictate interventions. So it's meeting people where they're at, what's going to work for them. And we try to enhance motivation by highlighting this discrepancy between where they are with their behavior and where they would like to be. Today, we'll talk about motivational interviewing within the context of alcohol use disorders, but I always say you can use motivational interviewing with any sort of lifestyle change, whether it's diet, exercise, medication adherence. This is really a useful tool as it relates to just basic, behavior and lifestyle changes. So I'll go through this kind of quickly in hopes that it's a review. When we think about motivational interviewing, we know that motivation is fluid, right? We all have intrinsic motivation to do a variety of things throughout the day, right? Our motivation changes. We might feel super motivated in the morning to tackle all that's on our to-do list. And as the day goes on and we start thinking about Thanksgiving and all the things we have to do, we might lose our steam. Same thing with substance use. People might be really motivated to, cut back or limit their drinking, and then a stressor comes up and suddenly that motivation changes. Motivation will change within the context of your relationship with the patient. If you're seeing somebody weekly or bi-monthly or monthly, their motivation will vary at each visit. We know that we can influence motivation by developing a therapeutic relationship, and we'll talk a little bit about addressing ambivalence and working with resistance. Sorry, my allergies are terrible, so bear with me. When we think about motivational interviewing, we really want to try to influence change in a positive direction. The key word is influence and not dictate or lecture. This really diverges from kind of our typical authoritarian model of practice. So techniques, reflective listening, expressing empathy. We'll see this a little bit in a few slides. We'll talk in more detail about really highlighting this discrepancy, as I mentioned, between where somebody is and where they want to be. I do a lot of motivational interviewing training with my students and with trainees at the VA. And I think as healthcare providers, we don't think that we argue with people, but it's natural at times. I think people tend to lecture and to provide people with all sorts of information to try to get them to change their behavior. And we know that doesn't work. So it can be really unnatural to roll with the resistance, as we say in motivational interviewing, rather than trying to persuade or convince people to change. The other thing is really supporting self-efficacy and optimism, providing positive reinforcement and affirmative statements. We'll see this on the next slide when we go through the motivational interviewing acronym, right? So a lot of this is just basic therapeutic communication, asking open-ended questions, affirming people. If the only thing that you can comment on that's positive is that the person's here for their appointment today, do it. Right? Maybe you feel like they are really kind of not willing to make any changes. You're concerned about them. The only thing you can affirm is, hey, they're here. They're having a conversation with you. That's still a step in the right direction. And then lastly, reflecting and summarizing are really just basic sound communication skills. So I've mentioned a few times developing a discrepancy. So asking people when we think about drinking, like, have you thought about cutting back? Have you thought about quitting? Your answer that you receive is going to vary. I've had patients say, like, of course I've thought about cutting back, right? I'm having liver problems. I fell and hit my head while I was drinking last week. I am having marital problems. Like, of course I'm thinking about it. Other people who are more pre-contemplative, if you think about the trans-theoretical model, might say, like, no, I don't really think there's a problem. Right. So getting a gauge of where they're at in their own stage of behavioral change. Asking people, like, what are the pros and cons about your drinking? What are the good things? What are the not so good things? People get something out of their alcohol or substance use, right? There's some sort of positive benefit. Otherwise, people wouldn't be drinking, and 1 in 10 people in the United States wouldn't have an alcohol use disorder. It's really helpful to know what the benefits are, because that might dictate how we approach the interaction. Somebody who says, well, I drink to avoid withdrawal symptoms, that's going to look really different than somebody who says, well, I have social anxiety and I drink so that I can relax, right? So knowing what the benefits is really helpful, but also putting this in the context of, well, what are the not so good things? When people tell you those two things back to back, it really highlights that cognitive dissonance. It really allows them to kind of verbalize and articulate what's helpful, what's not helpful, and sort of compare and contrast that. What are people willing to do? What has worked in the past? As you explore this, I also find it really helpful just to ask people, how confident are they to make some sort of change? How ready? Allow them to provide you that information on a scale of 1 to 10. And then it's really simple to say, well, why did you say a 5 out of 10 as opposed to a 10, as opposed to a 2, right? When you frame it like that, it kind of forces people to give, inadvertently, to give some sort of reason or explanation why they're ready or they're confident. I've had people say 1 out of 10, and I say, well, why did you say a 1 and not a 0? It makes them start to think, am I confident? Am I feeling ready? How can I do this? I talked a little bit about rolling with the resistance. So some people are not going to be willing to cut back or make a change, and that's okay, right? That's when we say, hey, I'm probably going to talk to you about this again. I respect your decision. And that's when we can move into the harm reduction piece. So we'll talk about medications. We can do things like thiamine supplementation for alcohol use disorder. For people who are drinking and driving, talking about rideshare programs, using those motivational interviewing skills. If they're not going to cut back on drinking, can they at least limit the number of times they're drinking while intoxicated? Thinking about binge drinking, right? So that's 5 or more drinks for males assigned at birth and 4 or more for females assigned at birth in a 2-hour window. We know binge drinking increases risk of acute injuries. So talking to them a little bit about maybe it's not realistic for them to stop drinking, but what are some ways they can drink in a safer way? There's also lots of public health initiatives that we might not have control of on an individual basis as providers, but that we certainly can advocate from a policy perspective. So things like tax changes, certain advertising bans. Not that this came up with alcohol, but with vaping quite a few years ago, nicotine products were being kind of like targeted towards adolescents, and there were certain advertising bans in that regard. I view some of these medications as harm reductionist in their approach, right? So they're helping people either eliminate drinking or in some cases, maybe not stop, but to drink less. We'll talk about FDA-approved medications, and then as I mentioned, we'll talk about off-label medications. I'm just trying to be cognizant of time. Just to reinforce, less than 10% of people with alcohol use disorder receive pharmacological treatment. So we know that these are very underutilized treatment interventions. Naltrexone, we know it comes in a daily by mouth formulation and also the extended release monthly injection. You can see here just some visuals. The study looked at harm reduction techniques with placebo, and then harm reduction techniques with extended release naltrexone compared to services as usual. And you can see pretty consistently in the blue, harm reduction coupled with extended release naltrexone tended to achieve better outcomes, not just during treatment, but also post-treatment. Just some prescribing kind of pearls. We monitor LFTs. There's a rare risk of suicidality, so that warrants at least talking about a safety plan. And then one thing that comes up is, do they have any sort of chronic pain that would potentially in the future warrant some sort of opioid treatment? Or is there some sort of upcoming acute pain likelihood? So like if somebody is going to need surgery in the future, if there's any chance that they'll need PRN opioids, this may not be the best option because it is an opioid antagonist and is contraindicated with opioid therapy. I find acamprosate to be pretty underutilized. The biggest downside I hear for people taking acamprosate is it's TID dosing, and they take 2 tablets, and the tablets tend to be pretty large. But aside from that, it tends to be fairly well tolerated. We monitor renal function, and there is a dose adjustment, if they have severe renal insufficiency. This tends to be more effective if people have had some period of abstinence. And as I mentioned, we have this TID dosing. I have a lot of people who have nausea and vomiting, just again, with the frequency that they take this. So that's something to be cognizant of. And then lastly, getting into off-label medications, there's some evidence for gabapentin in the treatment of alcohol use disorders. I didn't cover antabuse, but just as an FYI, we know antabuse is, I don't really view that as necessarily a harm reduction approach, but we can use antabuse as well. I have some patients that had been on it in the past and request it. So I typically start with acamprosate or naltrexone, just as they're FDA approved and have the most evidence before moving into some of these off-label medications. Gabapentin, I use fairly cautiously. You can see here there's some evidence that gabapentin can be effective in reducing the number of drinking days or increasing the number of abstinent days. And then lastly, there's some evidence for Topamax. So this study looked at Topamax versus placebo over a period of about 3 months. And you can see with the Topamax, there tended to be a greater reduction in number of heavy drinking days. Some additional information about gabapentin. I know I'm running short on time and we want to get to the case, so I think these slides should be shared with you, and if they're not, I can send them in the chat if that's okay with the facilitators. This is also here for your reference. And then with that, I don't know if we'll go right into the case or we'll open it up to questions. I will defer to the Project Echo team, but thank you so much for your time and attention. You guys are right, 20 minutes goes really, really fast.
Thank you so much, Brayden, and thank you so much for a wonderful presentation. I will open up the floor for any questions or comments from our learning community here. Carolyn.
Hi there. Thank you for this wonderful presentation. One thing I've been wondering is when we're looking at the rates of what's considered heavy drinking, and you mentioned male assigned folks versus female assigned folks, I'm wondering, what is that correlated to? Is it correlated to body weight? How is that determined?
Sorry, I was muted. So yeah, it's a good question. So the guidelines as far as, so there's binge drinking guidelines, which we talked about. There's also guidelines from the NIAAA just about weekly use. So the guidelines for like what they consider safe is 7 drinks a week for females and people over 65, and then 14 drinks per week for males. That has been the same for a long time. And the difference in sex and why the guidelines are different is thought to be related to metabolism and just like body fat distribution. Although I'm not sure that these have been updated recently or re-reviewed, if that answers your question.
Okay, that's helpful. Thank you.
Yeah.
I see a question here in the chat from Melissa. What are the reasons for being cautious with gabapentin? Are studies showing that it is also habit forming?
Yeah, and so that's part of the reason I do tend to be a little bit more conservative with gabapentin. Although I will say I've had patients that have responded really, really well to gabapentin as it relates to reducing alcohol cravings. There is some early evidence, and I feel like there's more like case reports than a ton of true research, but that gabapentin can be misused. And there's actually quite a few states that are now like including gabapentin in their PDMP. I'm from Pennsylvania, so West Virginia is an example. When you search their prescription drug monitoring program, gabapentin now appears. It's almost like they're viewing it as a controlled substance. I will say when taken as prescribed, when taken by mouth, when dosed appropriately, I don't feel like people experience much sedation or much euphoria, right? I feel like when we're seeing gabapentin be misused, it's often with other controlled substances. So it just depends on sort of your risk stratification. But I do start at a pretty low dose and monitor people, at least initially, when starting them on gabapentin a little bit more closely. Yeah, and Mary said it's being snorted. So I've heard that too. So that's why I said when you take it as prescribed by mouth, I find that most people do okay. But I have heard of people manipulating it and using it, insufflating it as well.
Thank you.
Yeah, I think that if nothing else is around, then people might abuse it, but it's not as reinforcing as
I don't
like
feel
your average abusable drug. Yes,
that's how I feel. I don't feel like people were really like going wild for gabapentin, but right, in settings where there may not be other options, I suppose it could be.
It's more like an in jail kind of
yeah
drug. But
well, it's funny you say that because
you always do want to and for people that do get sedated, you don't want them driving, or if they drink on top of it, it's going to be even more so. I think one of the things that people have been noticing is that it's often a substance that goes along in overdoses, and so there's some additional concern that maybe it's got some independent effect on, you know, mortality and things like that, but it's almost always in conjunction with opioids.
Yeah, it's funny you say that too, because the only patients that I've ever heard of, you know, taking it and insufflating it have been on an inpatient basis when they certainly didn't have access to anything else. So I think in isolation, if people are monitored, I don't feel like a ton of people are misusing it, but yeah, good point.
Yeah, I have to agree with that.
Adrian?
Thanks, Brayden. This is a really great presentation. I was just curious your thoughts on, why do you think that medications for alcohol use disorder are still so underutilized, and what can we all be doing to help increase their utilization?
Yeah, that's a really good question. I think it's kind of a twofold answer. I think number one is we talked about a lot of people are not accurately identified as having an alcohol use disorder, right? So we have, swaths of people who probably meet criteria, but are just flying under the radar, right? They're maybe not engaged in mental health services or even primary care services. But I think of people who are diagnosed with an alcohol use disorder, I still think, unfortunately, we see this with opioid use medications, although I think to a little bit of a lesser extent. There's sort of this stigma or trepidation about prescribing it, I feel like, amongst non-addiction specialists. So I hear PCPs, at least in my practice setting, saying like, well, I don't know, I didn't know if I should start them on naltrexone, and then I put in the referral and they were lost to follow-up. It really seems to be sort of a system issue where, if you have somebody in front of you today and you can get them started on something, I feel like that's best practice, because we know people may not come back if they're not getting their needs met initially.
And I think, one of the other things that you alluded to there is that people haven't really treated the condition before. And, they have some trepidation and, but, so having that experience of treating people, having it more available for trainees, in general, programs to have that opportunity, then you're going to be more likely to see people, starting it, even if they feel like the person needs a specialist.
Yeah, absolutely.
I'll also point out my experience is that a lot of patients, there's such notoriety around antabuse and how sick it has made some individuals. When medications are offered, patients will immediately be hesitant and say, oh, no, I don't want to be sick as a dog. And taking the time to explain the differences in all of the medications available. But I encounter that quite often where there's an initial resistance. And if there's a prescriber that may not be as familiar with that resistance, and someone just says, oh no, I don't want naltrexone, or I don't want a camprosate because it'll make me sick, they may not know to dig deeper into that.
Yeah, absolutely. I have definitely seen that. I think especially people who have had chronic alcohol use disorder for years or sometimes decades, they do perceive that the medications will negatively impact them.
And it's funny too, because its reputation is much outsized, because how many of those people have actually ever had an antabuse reaction? It's right. They've rarely even had any medicine. It's just that they remember that they could get sick maybe.
And like I said, I don't jump to antabuse very often, because I just feel like it's not really addressing the underlying neurobiology the way some of the other medications can. But I have some people who had been on it, they love it, that really has helped them. So there are certain patients that also really works well for.
Yeah, antabuse works if you're afraid to drink.
Yeah.
Then it works the best if people, just have made up their mind that they're going to use it that way.
So this has been a wonderful conversation. I will, though, pull up, there was one question that I wanted to point out from William. What do you think about using benzo for the first few days and then tapering it off? Brayden, you're mute.
Yeah, I think if they are at risk for, especially if they're at risk for withdrawal symptoms, we do ambulatory detox at my clinic fairly often if people don't have any history of complicated withdrawal, if their withdrawal symptoms are fairly mild. You know, we'll give them a very short supply. Sometimes we'll even see them back the next day. So I do think that can be appropriate. Just, it's important to be very explicitly clear. I have found that even when I feel like I'm being very clear, hey, this is going to be a 3 to 5 day thing, people come back and they're like, well, I feel so good. Then that you want to be very clear on expectations that they're not going to stay on the benzo, because I've had people who, of course, they feel really good. But I think that's, you know, appropriate in some instances.
Thank you so much. And this has been a wonderful discussion. We'll keep the chat going. Please keep putting your comments and questions for Brayden. But in the interest of time, we will move on to the next part of our session. Karen, if you could please bring up the announcements from the BVAL program. The Center for Substance Use Training and Telementoring provides high-quality education and best practices for responding to substance use. CSTAT can help enhance professional knowledge and self-efficacy to screen, treat, and make referrals for people with substance use disorders. To learn more, please visit us at cstat.utisca.edu. Next slide. To claim your CME credits, you must text by midnight tonight. You have to text attend 100-95-104 to 844-502-1338. We will also put this information in the chat. Next slide. Do you have a difficult case that you or your team have encountered? CSTAT provides you the opportunity to present any challenge your organization is encountering and receive feedback from our hub of experts and broader learning community. There is no need to prepare a formal presentation. We will provide a case form to fill out to assist with your case presentation. Please email us at cstat@utisca.edu. Next slide. Join BVAL Texas for an informational session to learn more about the BVAL Texas Clinic low and no cost treatments and services. To register, scan the QR code provided or register with the link provided. We'll drop this in the chat as well. Next slide. Our next TxRx session is on Tuesday, December 19th. Please to join us. We have an interesting session with Dr. Adam Bisaga. Next slide. Texas 2024 is now officially open to sponsors and exhibitors. The Texas Symposium will be taking place on February 29th and March 1st in Austin, Texas. If you're interested in learning more on how to become a sponsor or an exhibitor, please visit texas.org/sponsor-Texas. And now we will move on to the case presentation. Karen, if you could please share the case form, and Elisa, you can take it away. Thank you so much.
Hello, can everyone see me and hear me okay?
Yes.
Okay, perfect. So the case that I'm presenting today, I'm kind of stepping in for one of my colleagues who's under the weather. The case that we're presenting is it's more just to kind of ask about side effect profiles and see if anyone's had any experience, because in discussing this case with some of our colleagues here who've been doing addiction medicine for 10 plus years, this is the first time that many of us have seen this. So I wanted to hear feedback from other people. So and just for some background, we work at Healthcare for the Homeless Houston. So many of our clients are street homeless. Some have just been housed in permanent supportive housing. Many are in transitional living and rehab situations, things like that. So the majority of our clients are uninsured. So the patient that I'm referring to today is a 29-year-old female. And the questions that we'd like to address are if anyone has experience with lower extremity edema as a side effect of buprenorphine, and if so, how did you manage? How did your treatment plan change? Just kind of talk through your process with this. So scrolling down a little bit, this client, just a bit of background. I've been seeing her, I'm a psychiatry provider and an addiction provider. So I've been seeing her for psychiatry for some years, and she was in a longer term treatment program where buprenorphine was not allowed. Recently, she left the program and was housed in an apartment. However, the apartment that she was given in an area where she previously used her substances, engaged in survival sex work, etc. So immediately upon moving there, she started to have some cravings and some symptoms coming back. So her primary diagnosis would be, it was opioid use disorder, and it would be in remission at this point because she hadn't used in about 2 years or so. Aside from, so currently, just generally speaking, in terms of substance use, she did start using cannabis again after she discharged from her program. She reported once a day at most, maybe twice, just kind of depending on level of stress and access. History of methamphetamine use, last use in 2022. History of heroin use, IV route, last use 2020, prior to incarceration. And from her incarceration, she went directly to this treatment program. And history of PCP use as well. But as she reported to us, she really wasn't having cravings for any PCP, any methamphetamine. It was solely opioids and heroin use. As I mentioned, she'd been in counseling in the past, and no history of methadone or naltrexone or formal naltrexone treatment. But if I remember correctly, I think she had taken naltrexone possibly off the street once or twice and had some negative side effects with it. She has history of major depressive disorder and some pretty severe PTSD as well. And I think she specifically was worried about the risk of suicidality with it. Although she had been stable just in terms of her mental health for nearly about 2 years. So coming down to the DSM-5 criteria, the main issue that she was having was cravings for substances. She really doesn't meet criteria otherwise over the past 12 months, which, as she had been in a treatment program. However, prior to that, she absolutely met the criteria for opioid use disorder and formerly, polysubstance use disorder as well. If we can scroll down. So we started her off on buprenorphine. So we started her on films. Just the way that our program works, since most of our patients are uninsured, we contract with a pharmacy, and generally we stock tabs, but this patient requested films. So we started her off on films, increasing up to a BID dosing, just depending on her level of cravings, of course. So about 1 week after initiation, we had her follow up. She had some breakthrough, and she had a little bit of weight gain. Maybe, I'm going off memory here, maybe 4 or 5 pounds, which we thought was a bit unusual. It's a mild constipation. So we gave her a stool softener and increased her dosing just to try to target those breakthrough cravings. So she came back 1 week later and had bilateral swelling in both of her legs, and significant lower back pain. And she reported lower abdominal swelling as well. So we decreased to 1 tab, and we changed it from films because myself, our associate medical director, we had never seen this. So we were doing some research, and I don't know if it was just kind of general terminology used in the research, but we saw that lower extremity edema was like, there's a 5% chance of it occurring with films. And we didn't see with tabs. Again, I don't know if it was just written as films to kind of signify all forms of buprenorphine, but we decided why not? We'll decrease it. We tried tabs. We gave her 40 milligrams of Lasix daily. We checked her labs. She had also gone to the emergency room to rule out any DVT or anything like that. Of course, it was bilateral, but everything was normal. So she came back to see us a week later. Her weight had returned to normal bowel movements. But again, of course, an increase in cravings again. So what we ended up doing was referring her to cardiology, again, to rule out anything that we're missing. And we've retried her on BID dosing of tabs. And this was last week. So we actually see her again today. So really the feedback that I was hoping for is just, as I mentioned, we're really fortunate here. I work within a primary care clinic, and I spoke with some of the docs here, some of the other providers who've done addiction medicine for 10 years and are addiction boarded, and they'd literally never seen this before. So of course we are kind of doing the full workup for her, but in doing the research, I saw that 5% of people can have this. So I wasn't sure if that was unusual for other people to see. And I wanted to get other people's feedback on what they have done, if they've seen it, how they've managed it. Do they end up stopping the buprenorphine? And just hear what y'all had to say. So any feedback appreciated.
Thank you so much, Elisa, for bringing this case to us and sharing it. And I will open up the floor for any questions or comments from a community here.
So personally, yes, I have seen this. So when we were using films in our detox facility, we would have, I don't know, maybe 5 to 10 patients a year, and we see about 20 patients a week. So it's a really small percentage, but we would get individuals with peripheral edema most of the time in the lower extremities. And we would just use conservative treatment, non-medications, like elevating lower extremities, allowing them time, because we weren't sure if it was due to them being in a facility where they're receiving treatment and in groups all day, and an increased sitting, prolonged sitting or standing and things of that nature. But like you said, some of the research did show that there was increased peripheral edema with the films. I have not seen it since switching to the sublingual tablets. It is incredibly, incredibly rare. I haven't seen lower extremity edema maybe once in 2 years that was thought to be from the medication. Now, back when, many years ago, when we were using the films, I noticed that it was short-lived. Like once the patient got acclimated to it and with some conservative treatment, it didn't last the entire time they were on the films. It would be maybe the first week, first 2 weeks, and we wouldn't stop their buprenorphine, because as long as you're ruling out all of the other dangerous stuff, like you're doing DVTs and CHF and things like that, then the risk of taking someone off of that buprenorphine outweighed the risk of the lower extremity edema, as long as we were following up with it. So that's my clinical experience from it.
That's really helpful, because as I said, like in doing just, looking through the research, it very specifically said in films where they'd see it. So we were like, well, it may not make a difference, but let's try the tabs. And just, I'm seeing some of the questions pop up in the chat too. And we are in the process of getting her into cardiology. So the issue with us is that with patients with no insurance, we have to get them what's called a gold card. I don't know if you're familiar in Harris County, and then get them into specialty care. So it's probably going to take a little bit of time. But lab-wise, everything was normal, everything across the board. And she had no history, she'd been seeing medical with us and was consistent on that follow-up. And her job is actually in retail, and she's standing all day, most of the day. And then maybe a little bit more sedentary after work, but not, like we would see in a rehab, like an inpatient environment. So we kind of looked at the whole social circumstances too, and we were just like, we didn't know.
Well, prolonged standing can lead to dependent edema as well. Do you have an ability to get her something like compression stockings for while she's working?
Occasionally we do get donations of those. It was very quick. Like within a week, it was like 10 to 15 pound weight gain. And this is not a new job for her. This is something she had been doing for 6+ months. So it was so fast that we felt like it was something, when we had just started the buprenorphine, and we're like, oh boy, like, Of course, there's possibility of other things, but with this being a risk with the buprenorphine, it kind of seemed like the first thing to rule out. But as you mentioned, we didn't want to stop it either because her risk of relapse was so high at this point.
Yeah, I Googled around on this a little bit yesterday because I can't say that I've really, seen this myself, but I just don't see the volume that Dr. Walker does. But that seems to make a good case for there's something weird about that combination that may make it more likely than just the buprenorphine monoproduct. It also seems like it could have to do with just dosage, and because she's not currently dependent on opiates, and that's a pretty good slug of opiates to get in a short period of time. And as Crystal was saying, maybe a little bit slower, her system get used to it, maybe she could tolerate a little bit more, or split the dosing so it's lasting a little bit better. Is she getting her dosing every day there, or does she get a prescription and she takes it at home?
She takes it at home. She gets a weekly.
Okay, so she could split it up into 4 twice a day or whatever, in case it has something to do with that. But I noticed too that this peripheral edema can happen with a lot of different opiates, not just buprenorphine. So it seems like a potential adverse effect that can happen with a number of things. And actually what they do if it happens with one opioid is switch to a different one, and it might not actually happen with that. Unfortunately, her only other choice would be methadone if the buprenorphine really wasn't tolerated.
And it sounds like she's only been on it for what, 2 weeks, 3 weeks now?
Yeah.
Yes, but she had been on it in the past.
Gotcha. Was it a different formulation in the past, or was it films in the past as well?
So, prescribed tabs, but had to get films.
Gotcha. Well, and there's also a question of consistency, right? If she was getting a prescription of tabs and had no issues, and then was just spot taking films from the street or friends or family, then it wasn't a consistent every day taking the films like she has with your prescription, which may make a difference of why, I haven't encountered this before with the films, but you are also only taking maybe it sporadically and not as a consistent prescription. But I saw it with both the mono product and the dual product with films. So both the bupe and the bupe naloxone films, I would occasionally see the peripheral edema. And so I don't think that it has anything to do with the naloxone, but just anecdotally from my clinical experience, it's because of the films specifically. But I haven't really encountered it with either formulation of tabs, mono product or dual product. And even when I did have it with the films, like I was saying, it was only for a couple of weeks. So 1 or 2 things might be happening. Either you guys are switching the formulation and the peripheral edema is subsiding, or she's getting more tolerant to that one specific side effect.
That makes sense.
Oh, hey, I just wanted to add something. Sorry, my camera's off. I'm eating lunch. But I worked at LBJ in the ER for a long time. And if you are even remotely concerned that she's got CHF and it's taking you a long time to get her into care, she can go to LBJ with chief complaint, new onset peripheral edema. It's a teaching hospital and they love teaching ultrasound stuff. So good chance someone will just slap an echo right on there and take a look. But if you're having a hard time, LBJ is a good resource.
Thank you. I think that's kind of our backup plan. Just sort of depending on how she does, but especially with all her blood work being normal, and truthfully, the client doesn't get too excited about going to the ER and all that. So that was even just getting her to go to urgent care just to have a Doppler was a long conversation. So, but I appreciate that. Thank you very much.
Thank you. And Was wondering, in the interest of time, Dr. King, if you could perhaps summarize some of the key points and recommendations for Lisa.
Sure. Yeah, this is a little bit more unusual case that we've got here, but interesting nonetheless. I think certainly any of the newer prescribers might hit this on some odd time and wonder what the heck is going on. So I think it was a very interesting case to hear about. So a 29-year-old woman without really any cardiac history or any significant medical history that we're really aware of. Had been exposed to buprenorphine in the past without problems, had now been off opioids 2 years or so, quite a long time, but was started on buprenorphine due to significant craving and concern for her having a recurrence of her opiate use, and then rapidly developed lower extremity edema. Workup, really nothing to write home about. The clinicians worried that there could be something hidden or very significant, and I guess we don't really know the results of switching the formulation, which seemed to be the thing to do. But hopefully we'll get some follow-up. Maybe Alyssa could fill us in if she can't come next month. Maybe you could send word in some way and let us know how this all turns out.
I'm literally seeing her in 30 minutes, so I'll let you know next time.
Okay, yeah, that would be very interesting. But it seems like there was some experience with Dr. Walker of similar kinds of symptoms, and that it may be dosage or formulation related. And tincture of time, perhaps, is one of the principles we would use here, and just taking a very sort of practical approach to trying to minimize the side effects while the patient gets stabilized, either on a formulation that she seems to tolerate better, or maybe even what's available just over a longer period of time, since it seems like the general experience is that this lower extremity edema tends to resolve after a couple of weeks. That sound reasonable, Dr. Walker? Yeah, okay, good. Getting the nod.
Thank you so much, Dr. King, and thank you all for joining today's ECHO session. As a reminder, to earn C credits, please text the activity code 1009-5104 to 844-502-1338 by midnight today. We also request you to complete the post-session survey using the link in the chat. The survey link will be open for 1 week. If you'd like to present a case, please email bvaltx@ithaca.edu. We look forward to seeing you at our next session on Tuesday, December 19th. Have a wonderful rest of your day and happy Thanksgiving. Have a good one. Bye-bye, everybody.
Bye.